بسم الله. هذه الهيد وسباين تروما. الجول في هذه المحاضرة إنه to understand the head and spine traumas and the main goal of managing these patients. So patients who come in with traumatic brain injury, the main goal is to prevent any secondary injury from hypoxia, because that leads to further exacerbation of their initial injury. Okay, so background, 90%, 90% of trauma-related deaths in the field are due to brain injury. So this tells you of how significant this subject is. 75% of those with head injuries receiving medical attention are mild, 15% are moderate, and 10% are severe. So this also gives you an indication of that mild injuries compose 75% of all head injuries, and 10% are severe, which is not an insignificant number, meaning that 1 in each 10 patients who comes in with a head injury is going to be a severe head injury. Anatomy, we have to understand that the scalp is a vascular area that's heavily vascular, that can lead to significant bleeding, that may even lead to hypovolemia and death secondary to hypovolemia. So you have to close and control the bleeding from the scalp early. The skull is the rigid container of the brain. It has an irregular base. It has an anterior fossa, which has the frontal lobes, and then has the middle fossa, which has the temporal lobes, and the posterior fossa, which has the excuse me, the lower brainstem and the cerebellum. And then we have the meninges. Meninges has the dura mater, arachnoid mater, and pia mater. And then we have the brain, which is the cerebrum, the right and left hemispheres separated by the falx cerebri, and then the brainstem and cerebellum. And then you have the ventricular system, which deals with the CSF, cerebrospinal fluid. And then you have the intracranial compartments, so supratentorium, infratentorium, which are separated by the tentorium cerebelli. The uncus, which is the medial part of the temporal lobe, herniates through the tentorial notch, leading to uncal herniation. Uncal herniation, how do you know this clinically? It causes ipsilateral pupillary dilatation and contralateral hemiparesis. So same side pupil dilation, and then opposite side hemiparesis. Okay, we talked about all of these. Move on to physiology. So the normal ICP, the normal brain ICP is how much? Shukran. 10 millimeters of mercury. Okay. So we have to know or understand at least the Monroe-Kelly doctrine. So the doctrine tells us that basically the volume of components within a given space must remain constant. So when normal volume is exceeded, the pressure increases. Okay, so some compensation can happen with release of venous flow and CSF, but once the limit of this buffering of releasing CSF and venous flow is exceeded, and the volume rapidly expands from a rapidly expanding hematoma, we have a rapid increase in ICP, which leads to herniation. Tamam? Cerebral blood flow. Cerebral blood flow can decrease for 2 to 3 hours post-injury, but for patients who remain comatose, So CBF, cerebral blood flow, can actually remain low for days to weeks, which can lead to بالمنطق يعني reduced cerebral blood flow, reduced oxygenation, increasing brain injury. تمام. بعدين وعندنا capillary system. It can constrict or dilate in responses to changes in MAP, which is the mean arterial pressure. طيب, what's the mean arterial pressure important for? Mean arterial pressure minus the intracranial pressure gives us the cerebral perfusion. So CPP of 50 to 150 can be auto-regulated. As long as the MAP minus ICP is between 50 and 150, it can be auto-regulated by the brain. تمام. لكن severe TBI, traumatic brain injury, can disrupt auto-regulation. And then a MAP that's too low can lead to infarction. A MAP that's too high can lead to elevated ICP and swelling. What are things that can worsen a brain injury? Low oxygen, hypercapnia, hypotension. These can all worsen the brain injury. This is why it's important to have a PaO2 وال PaCO2. طيب, هذا اللي كنا نتكلم عنها من ناحية شو اسمه compensation for the volume pressure curve. So this is the ICP and this is the volume. So it can continue to have a constant blood pressure until at some point the limit of the buffering زي ما قلنا is exceeded from, let's say, a rapidly increasing hematoma, and then the blood pressure, the ICP goes very high up, and once it goes up, then you have the herniation. And this is just an explanation of what the doctrine is. So let's say that both of these are closed. تمام. This is the normal state. You have CSF, you have brain, you have arterial or venous. تمام. Compensated state, هذا اللي قلنا فيها البفرنج. شوي من الفينس فوليوم يطلع, شوي من CSF يطلع. It compensates for this mass. So we have still normal ICP. But if we have a large mass which can also be a hematoma, rapidly expanding hematoma, then you have a huge amount of the CSF coming out, a huge amount of venous volume coming out. You get to a decompensated state, which really leads to an increased ICP. So what's the classification of head injuries? We have mild, which is a GCS of 13 to 15. We have moderate, which is a GCS of 9 to 12. And then we have a severe, which is the GCS of 8 or less. Tamam? So how is this significant? It's just significant for the classification. We have types of head injuries. We have fractures, intracranial injuries, so epidural, subdural, intracerebral hematomas. And then we have diffuse, concussion, contusion, hypoxic ischemic injuries, or diffuse axonal injury, DAI. Skull fractures, linear. I'm just going to show you pictures of what these can be. So this is a linear injury, very simple. It's linear. Stellate, which is this one, and you can see how expansive this injury is. Tamam. So linear basically is one line. Stellate is multiple lines conjoined together. Skull fractures. What's going on here? So this is a depressed skull fracture. Okay, you can see it. It's inside. It's actually gone through the bone. So this is a part of the skull that's actually depressed into the brain. The significance of this is that it can cause compression to the brain itself. So it needs to be lifted most of the time. Basilar skull fractures are very concerning. We've talked about the signs of basilar skull fractures before, but we'll go over them really quickly. Battle sign, which is this one, and then hemotympanum, which is this one. And then we have CSF autouria or CSF on rhinorrhea. So CSF coming through the nose or ears. This is how you can tell that this is CSF. It has the halo sign when you actually put it on a piece of paper or a napkin or a tissue. And then raccoon eyes, which can be on one side or both, meaning it can be on the upper lid, lower lid, or both upper and lower lids. It can be on one eye or both eyes, depending on what the mechanism is and depending on what the significance of the brain basilar skull fracture or injury is. Intracranial injuries, we have focal, meaning we have just a significant, a small area that was significantly injured. We have epidural versus subdural, and then we have contusion, and we have the coup contre coup, meaning that if you have an injury here, sometimes the brain can move, and then you'll have an injury that's on the other side of it, on the opposite side exactly, from the movement of the brain from one side to the other, secondary to an injury from one side. So if you get hit from here, you'll have an injury here, but you'll also have an injury here because the brain moves this way. Okay? We'll talk about the epidural versus the subdural and the differences between them. And then this is the focal bleed. What's the difference between the epidural and the subdural? So subdural, between the arachnoid matter and the dura mater, between the dura mater and the skull. Epidural is between the dura mater and the skull. Subdural, between the arachnoid matter and the dura mater. What are the differences between these two things? The epidural has a lucid interval, meaning the patient can have an epidural but be initially fine. This is typically the classic presentation. It's not always there, but it's someone who comes in feeling fine, nothing happened, and then all of a sudden they decompensate. So they have a lucid interval where they're normal before they become very bad. Immediate progressive in the subdural, it doesn't have a lucid interval. The shape, this is biconvex, so it looks like a lens basically, and then crescent, which looks like a crescent. The vessel involved typically is the middle meningeal artery in the epidural, and then the bridging veins in the subdural. Intracranial injuries, we want to talk about the management of them. So mild, we want to take a complete history and full examination. What are some of the tools that we can use for the mild and moderate or mild head injuries? أشكركم على الحماس. طيب في الكنديان سي تي هيد رول وفي النكسس رولز that can be sorry A and والبيكارن. These can all be used for C-spine and head injuries. Full neurological examination, very detailed history is very important in these patients, and then imaging as needed. Drug and alcohol screen as needed as well. So if we're suspecting that the patient had an injury secondary to alcohol, or if the patient's altered mental status is due to a drug or alcohol ingestion. Canadian CT head rule, I'm not going to go over the details. You must know them. And I cannot stress this enough. You must know the CT head rule. It explains that CT head is only required for minor head injury patients with any one of these findings. So if they have high risk, this means high risk for neurological intervention, GCS less than 15 at 2 hours after, suspected open or depressed skull fracture, any sign of basal skull fracture, vomiting 2 or more episodes, age above 65, meaning that anyone above the age of 65 or above gets excluded from this and has to get a CT head regardless of what the clinical situation is in the head injury scenario patient. Medium risk, amnesia before impact, 30 or more minutes, dangerous mechanisms. And then you have to actually read the Canadian CHEAD rules definitions of what signs of basal skull fracture is, dangerous mechanism is, and then the rule out. So GCS, age, I think if they're on any blood thinners or are have any bleeding disorders such as hemophilia and so on and so forth. On the opposite side, what's the indication for CT head? Any neurological deficit, GCS less than 15, 2 hours after the injury, open skull fracture, basal skull fracture, more than 2 episodes of vomiting, extremes of age, retrograde amnesia, severe headache. How do we manage head injury patients and moderate head injury patients? Initially as mild, but then you have to admit for observation and repeat exams, meaning neurological exams and imaging as needed. Early neurosurgical consultation, and then if any deterioration happens, then you manage them as severe. How do we manage severe? We have to resuscitate them, early intubation, early neurosurgical consultation, frequent evaluation, examination, and imaging as needed. Special considerations to keep in mind when dealing with the severely injured head injury patients: mannitol, hypertonic saline, and anticonvulsants. Also sedation and paralytics as needed. What's the goal for brain injured patients? A, B, C, D, E as for every patient, but you want to minimize the secondary brain injury through prevention of hypoxia and acidosis. Maintain adequate ventilation throughout their stay, maintain their blood pressure above 90 throughout their stay, and then consult neurosurgery early on. That's basically it for the brain injury patients, head trauma. So we'll talk about the spine trauma now. A little bit of background as something to know that 5% of patients with brain injury have an associated spine injury. So that's something to keep in mind. And then 25% of patients with spine injury have associated at least mild brain injury. The majority of the fractures you can see are injuries are in the cervical spine, 15% thoracic, 15% thoracolumbar, 15% lumbosacral. Patients with an injury in one portion of the spine, 10% of them have a second non-contiguous, meaning in a different zone of the C-spine, of the spine itself, not just the C-spine. Anatomy, I'm sure you know this, we have 7 cervical vertebrae. We have 12 thoracic, 5 lumbar, 5 sacrum, which are fused, and then the coccyx, which is 4 of them, which is fused. Okay. Key myotomes, I'm not going to go over these, but you have to remember them just for your own sake, because this helps you significantly in the examination of a patient with a suspected neurological or spinal injury. When to suspect that a patient has a spinal injury: if the patient has multiple injuries, has a head injury, is a patient who's a trauma patient that's unconscious, has focal neurological deficits, has spinal tenderness. When we have to differentiate between a complete injury and a incomplete injury. So if there's no motor or sensory below the level of the injury site, then that's complete injury. If it's an incomplete injury, then any motor or sensory below level tells you that this is an incomplete injury, knowing that sacral sparing may be the only residual function, meaning that the patient only has sensation around the sacrum itself. That's it. How do I protect the C-spine? Immobilization until the actual injury is ruled out, whether clinically or radiologically. Canadian C-spine rule, similar to the Canadian CT head rule. You have to know this, simple and plain. It's a very theoretical thing, but you have to know it. And then there is another rule, which is the NEXUS rule. You can be asked about one of these two at any point in time. Wink, wink. Management. So ABCDE as usual for spinal injured patients. Immobilization of these patients. Imaging as you need, and then early spine service, whether this service is from orthopedics or neurosurgery as needed. We have to also look for a specific type of shock, which is neurogenic shock. What's neurogenic shock? It's a cardiovascular phenomenon due to the loss of vascular tone. It's typically associated with a cervical and high thoracic spine injuries. Usually presents with hypotension and bradycardia. How do we manage these patients? We give them atropine, vasopressors, and we give them fluid resuscitation. Tamam? Spinal shock, it's neurologic and not vascular, زي neurogenic shock. It typically happens shortly after the spinal injury. It's a variable duration. It typically presents with flaccidity and loss of tone. Other considerations in patients with cervical spine: ensure that the patient's resuscitated, is well ventilated, especially for a neurogenic and a spinal shock. Make sure that if the patient has an injury above the diaphragm level, that they have adequate ventilation. Keep in mind that especially in patients with high spinal injuries, will have limited abdominal examination just because of the loss of sensory and motor below it. And then make sure that you always evaluate the limbs in those spinal and neurologically injured patients. Evaluate the limbs for compartment syndrome because they may have loss of sensory function, so they won't be able to feel pain and let you know that they have these issues. Cervical spine imaging, cross-table films can rule out only 85% of fractures. Adding odontoid views and AP views can rule out most, but it's not the best imaging technique for ruling out C-spine injuries. Swimmer's view may be indicated, in which you lift the arms above the head so you can actually get a closer look at the lower C-spine on X-ray. What's the minimum required to see on C-spine to say that it's adequate? أي أحد تكفون. طيب, you have to see C1 through T1 لازم, in order for this to be adequate as a C-spine film. Okay, CT and MRI are next imaging modalities. This is the C-spine X-ray from the lateral, at least. These are the lines that you want to see, and make sure that they align before you say that this is a normal C-spine X-ray. So this is the posterior spinous line, which is basically the spinal processes. And then you have this, which is the spinolaminar line. And then you have this, which is the posterior vertebral line, and then the anterior vertebral line. You have to see through C1 through T1. ليش؟ لأن T1 acts as a fulcrum that the C-spine can actually be mobile over, but T1 isn't mobile. So you have to see all the way down to C7, because that's where a lot of fractures happen, because of the mobility of C7 and the C-spine above T1, which is fixed. T1 is fixed. So it makes it a common site for injuries. So this is the AP view, spinous processes, okay, and then basically the lateral vertebral bodies. And then we have the odontoid view. You can see the odontoid and then lateral masses of C1, And then you have the odontoid fractures depending on the type. And this is the swimmer's view in which you lift the head, the arms over the head, so you can get better imaging of C7 and or T1. This is a CT that shows a very nice fracture. So how do we know which level this is just by looking at it? What's this? This is the coccyx and the sacrum. So you go down to 5, 4, 3, 2, 1. So we know that this is L1. Okay. Specific C-spine injuries: Jefferson's fracture, Hangman's fracture, burst fracture. You need to know these. Know what the Jefferson's fracture is, what the Hangman's fracture is. A burst fracture, you don't need to know a burst fracture, but I'll show you in a second. Fracture dislocation, which is not only a fracture. This is the burst fracture, in which you can see the lateral masses have gone away from the central mass. It can happen at any level. It's usually from AP compression. Sorry, from vertical compression. What's this? Close. So this is C1. أي صح الأول باسل hangman. Yeah. Because this is C1, this is C2. Fractures in C2, so that's hangman fracture. They call it hangman because it typically happens in patients or victims who commit suicide or get hung, so by hanging. And then the Jefferson is C1. Okay, and typically it's a C1 burst fracture. So what's this? This is a fracture, but it's also a fracture dislocation. So that's why it's important to know. Yeah. This is also a fracture dislocation. Conclusion in C-spine injuries or spine injuries altogether: early recognition of brain injured patients, prevent secondary brain insult, especially in those who have traumatic brain injuries. So you want to make sure that they don't get hypoxic, they don't have hypoperfusion, so you don't exacerbate this injury. Early neurosurgical consultation for these patients, high index of suspicion for spinal injuries, immobilize the patients early, especially in the C-spine, early recognition of spinal and or neurogenic shock, and then early spine consult for the spinal patients. Any questions? أتحداكم تلقون واحد أحسن مني يخلصكم. بعدين ربع ساعة متأخر وبريك وخلصتكم قبل ب40 دقيقة. يلا. بس بطلع حقها بالأسئلة لا تخافون. Spinal shock management is just basically symptomatic and a supportive care. هذا وليد. طيب أنا بقول لكم عندي الإيميل بكتب لكم إياه. هذا اللي عنده أي شيء يرسل لي عليه. وعندي التويتر هاندل، بس خلوني أتذكر وش أصلا. مسوي فيها اني متطور يعني. اصبر، هذا وهذا @فهد IA1. اللي عنده اي سؤال يتذكره بعدين، سؤال منطقي شوي، يكلمني على واحد من هذول الاثنين. يعطيكم العافية جميعا وموفقين.